Hi, this is Manos Brilakis, and this is video 8.3.9 for the Manual of CTO Interventions. This is a video that discusses how to close saphenous vein grafts after recanalizing the native coronary CTO. There are three components of today's video. The first one is why we're doing it, the second is how to do it, and the third one is the special case of saphenous vein graft aneurysms. Starting with the why. Why should we close the vein graft? And this is important because quite often we can do nothing. We can open the native vessel CTO and potentially leave the saphenous vein graft alone. However, quite often we do want to occlude the saphenous vein graft, and the idea behind it is to reduce the risk of stent thrombosis of the native vessel. The comparative flow might decrease the undergrade flow through the native vessel, and that can lead to native thrombosis. And the best study for this is the study by Poletti and Agostoni, looking at what happened when you had the graft occluded or you had the graft patent after recanalizing the native artery CTO. And what they found is that when the graft was occluded, where there's STEMI flow less than 3, the outcomes in terms of the native CTO were much better than if there was strong TIMI3 flow into the saphenous vein graft. And again, these are small numbers, lots of limitations, but the whole point is if you have a strong competitive flow through the saphenous vein graft, there is a risk that the native vessel stents will suffer. So, and this is an example. This is when we have a native RCA CTO, a saphenous vein graft with recurrent failure. We were able to open the native CTO, but there is strong competitive flow into the PDA from the saphenous vein graft. So this graft was closed with an Amplatzer vascular plug. And now there is a good undergrade flow going into the PDA without competitive flow through the saphenous vein graft. So part 2, how can we actually close the vessel? And there are 4 different ways. One is to use coils. The second is to use an Amplatzer vascular plug or combination of the two. Third one is the Condom technique, a technique that doesn't require any specialized equipment. And fourth is to place a covered stent into the native vessel. So the first technique is to use coils, and this is one of the most common. The coil we use in our lab is the penumbra coil. And those come in different sizes, but we do use this so-called large volume system. And the whole idea is that you place a coil, either the ruby or the pod, sized 1:1 to the target vessel, and then to achieve better occlusion, one can insert an additional cold packing coil or liquid metal that is deployed just proximal to the original pod or ruby coil. And this is an example. Patient who had a saphenous vein graft that was occluded. We know that this vessel will not stay open if thereafter is recanalized. So we were successful in recanalizing the native right coronary artery, but now want to minimize the competitive flow. So what we did is we advanced a microcatheter, and these coils require a larger microcatheter. It's not our typical CTO microcatheters like the Corsair and Turnpike. This was actually a pro grade. These are larger, 2.6 to 2.8 French microcasters that allow for these larger coils to be deployed. Then we tried to deploy the coil in as tight a position as possible. Here, actually, this was not optimal. We'd like to have the coils very tightly packed together, and these are all the so-called detachable coils, which means if we don't like the way they are deployed, we can pull them back and then redeploy them, and then only release them once we're 100% comfortable with the location of the coils. So this is how it looks like after it's deployed. There is still some flow, and this is a message. Sometimes you may need to wait some time or place additional packing coils. This was, again, the ruby coil, but if we put in a packing coil that is tightly knit, then we can close the flow more effectively. Now, the second way to occlude the saphenous vein graft is to use an Amplatzer vascular plug. There are many types of Amplatzer vascular plugs. The one we have been using for closing vein grafts is the AVP2. It has 3 lobes and comes in different sizes. We try to oversize the plug by about 30 to 50%. So if the vessel is 4 millimeters in diameter, then we try to put a 6 millimeter AVP2. Another thing that is important for deploying those plugs is that their shaft is 100 centimeters. So to deliver them, we have to have a short guide catheter. If the guide is long, then we won't have enough reach of the shaft to deliver the vascular plug. The steps for getting the plug to the saphenous vein graft are, number one, to either use a short guide catheter or shorten the guide catheter. We typically use 90 centimeter guides for the retrograde approach, so that's not an issue. But if we're using 100 centimeter guides, we need to shorten them. And then we typically deliver those plugs using a guide catheter extension. How to shorten a guide catheter, that's shown in a separate video, but essentially we cut it and we use a connecting sheath, 1 French smaller than the size of the guide catheter. Then we actually load the Amplatzer vascular plug on the guide extension. This is a 6 French trap liner, and essentially we dip it into water to minimize air aspiration, and then we pull the Amplatzer vascular plug underwater until it enters inside the guide extension. We then deliver the guide extension along with the included vascular plug all the way until it gets to the vessel. It is important to be able to deliver the vascular plug and the guide extension without a wire. There's no wire going inside the graft, but the whole assembly of guide extension together with the contained vascular plug is pushed down the saphenous vein graft. Once we're happy with the position, then we try to deploy it. We deploy by turning counterclockwise using the included torquer, and we watch it under fluoroscopy. So we're turning counterclockwise, and then we watch it. And then once we see that the connecting rod is separated, then we pull the shaft back. And this is how it looks like. We're turning counterclockwise, and now it's disconnected, it's released, so we can pull it back out from the body. Sometimes, similar to the coils, the occlusion may not happen immediately. It may take a few minutes, but eventually it is successful. So this is after a few minutes. Now we do have successful occlusion of the vessel. Sometimes, if we have too brisk flow, despite using the vascular plug, then one can use coils as well. This is a CTO into the circumflex and the left main. This was successfully recanalized, but there is a lot of competitive flow. So we placed an Amplatzer vascular plug, but there's still very brisk flow despite the vascular plug. So we ended up putting an additional coil proximal to the plug, and this is a packing coil that can be put very tightly inside. And after doing that, we did have successful occlusion of the saphenous vein graft. The third way to occlude the saphenous vein graft is called the Condom technique. And the advantage of this is that it doesn't require any specific equipment, such as the coils and the Amplatzer vascular plug, and therefore it is cheaper and more universally available. Essentially, what is done is that the distal part of a standard angioplasty balloon is cut. So we have this balloon fragment that is inserted over the wire, and then we place an additional stent just proximal to this fragment of the balloon. This is delivered to the desired location, then the stent is deployed, and the stent essentially is fixing the balloon fragment against the wall of the vessel, effectively occluding the vessel. And this is how it looks like. The fragment is going down, and now we have successful occlusion of the flow through the saphenous vein graft. The fourth way for closing the saphenous vein graft is by using a covered stent in the native artery. So if everything else fails, or if there is not a good landing zone in the vein graft, then putting a covered stent into the native vessel will also work. The third segment of today's video is specific about the vein graft aneurysms, and this is very important because if one occludes only the proximal or only the distal part of the aneurysm will usually continue to grow. So you want to exclude the aneurysm completely from the circulation by occluding it both proximally as well as distal to the aneurysm. And this is an example of what not to do. This is an RCA CTO, and a saphenous vein graft that goes to the right and has a large aneurysm. CTs are often done. We can see the large size of the aneurysm, and there's distal anastomosis to the right coronary artery. So we recanalize the native RCA, which can be very complex, but is often done using the retrograde approach. And then in this case, a Amplatzer vascular plug was delivered and deployed into the proximal portion of the graft with successful occlusion proximally. But the problem is now we have still flow into the saphenous vein graft. We can see it here from the native coronary artery. So we should have first occluded the distal portion of the graft, but the problem here was the very short landing zone. So what one could have done instead is put a covered stent over here. Here is how it should be done. This is a case in which both ends of the aneurysmal vein graft were occluded. This was a patient with previous bypass again that had this very large aneurysm of the saphenous vein graft to the obtuse marginal branch. So a huge cavity. It measured 89 by 79 millimeters on the coronary CT. And for this one, we were able to get through, have a guide extension, recanalize the native vessel, and now we want to achieve occlusion of the saphenous vein graft. Once again, it has to happen both distally and proximal to the aneurysm. So we first went to the distal part, distal to the aneurysm, and we used a microcatheter and delivered several coils. And this graft was fairly large, so we had to place a ruby, as we mentioned before, for the structure, and then several packing coils proximal to it to occlude the distal portion of the graft, and this looks good here. But then we still need to close the inflow to the aneurysm, and this was done in this case using an Amplatzer vascular plug that was deployed and has really decreased the flow into the aneurysm. And this is the final angiogram. Again, we had occlusion both distally as well as proximal to the saphenous vein graft. So to summarize, the goals of closing the vein graft is to minimize the competitive flow and decrease the risk of thrombosis of the native stent that we place in the native coronary artery. Also, it can be used to treat the vein graft aneurysm, but as we discussed, if there is an aneurysm, it is critical to close both the proximal and the distal end of that vein graft so that there is no pressurization of the aneurysm cavity. How to close it? The most common are coils and Amplatzer vascular plugs, but the Condom technique, which is a balloon fragment with a stent, can be used, and also a covered stent can be placed in the native coronary artery. Thank you.